Dr. Balaga here. I have another terrific God Knowledge Doc podcast for physicians and advanced practice providers, including physician assistants and nurse practitioners. You should find this podcast very useful in your practice. Today, I will talk about door to GDMT time, connecting the dots between recent advances in heart failure GDMT and cardio-oncology. My disclosures are, I have a podcast called God Knowledge Doc. Many of the podcasts are on cardio-oncology, and I'm one of the editors for the International Cardio-Oncology Society Board Review Manual. Cancer-related cardiomyopathy is well recognized. In this terrific review by Dr. Jeremy Slivnik, one of our fellows, we know that the incidence of heart failure with chemotherapy-induced cardiomyopathy could be as high as 25%, and the burden continues to evolve as more and more medications in oncology are emerging. The four pillars for the treatment of heart failure are now ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. The early mortality in heart failure, based on the Framingham Heart Study, is 10% at 30 days. So within the first month, we lose 10% of our patients. At the end of 1 year, as high as 25%, and at 5-year follow-up, it's as high as 50%. The mortality continues to be high and is in a standstill and is as high as cancer. So our cardio-oncology patients have now two conditions which increased the burden of mortality. What is the mode of death in heart failure? In NYHA class 2 and class 3 heart failure, sudden death is the main reason for people dying. As high as 60% die of sudden death. It's only in class 4 heart failure that pump function, or CHF, is the predominant underlying cause of death. And this data is from the MERIT CHF study, which was published in the Lancet. Even in patients who are completely asymptomatic with left ventricular systolic dysfunction, the mortality is higher, and 40% of these are attributed to coronary artery disease, of which 43% die of sudden death. In our clinical practice, we tend to monitor left ventricular ejection fraction. This is a very elegant study in JACC which showed that Carvedilol improved left ventricular ejection fraction in anthracycline-induced cardiomyopathy. But I would like to emphasize that the benefits of GDMT is due to improvement in sudden death and left ventricular pump dysfunction. Beta blockers improve mortality in heart failure, as we all know, by reducing not only total mortality but also cardiovascular mortality, both due to sudden death and death from pump failure. Similarly, in the FSS study, eplerenone reduced sudden death by 21%. In the paradigm heart failure, there was a 20% reduction in sudden death with ARNI and a 21% reduction in heart failure death. So the improvement in LV function is not the only reason for improvement with the four horsemen, but also due to a reduction in sudden death. With SGLT2 inhibitors, in the DAPA heart failure, Dapagliflozin improved mortality by reducing ventricular arrhythmias, reducing the incidence of resuscitated cardiac arrest and sudden death. And I'd like to thank Dr. Muthu Vaduganathan from the Brigham and Women's Hospital for sharing the slide with me. So if a patient with HFrEF receives no therapy, at the end of 2 years, there's a 35% mortality. But with the treatment of these 4 new horsemen, the mortality is reduced at the end of 2 years to single digits. It's still pretty high at 9.5%, but the relative risk reduction is nearly 73%, and the absolute risk reduction is 25%, and the number needed to treat is 4. And this is work from Greg Fonerow, and I thank him for sharing this slide with me. Interestingly, Daniel Cardinal in JACC of 2010 and investigators showed that in Adriamycin cardiomyopathy, early administration of GDMT, there were better responders to left ventricular ejection fraction. In fact, if therapy was started early in the first 2 months, there was a 64% improvement in ejection fraction. As therapy was delayed, the responders decreased, and at the end of 6 months, there were no responders. And this is one of the early studies which emphasized the importance of early therapy with GDMT. In the Ephesus trial, when they looked at eplerenone, an early eplerenone administration within a week improved outcomes, including sudden death, whereas there was no benefit when eplerenone was initiated after a week. In the Pioneer Heart Failure study, David Morrow and colleagues looked at outcomes, and they found that the effect of ARNI, that is sacubitril valsartan, was early, and the curve separated out as early as 12 days. And you can see here that the efficacy lasted through 8 weeks. And when you look at NT-proBNP in the same study, the curves started separating out as early as 1 week. So the benefits are early with ARNI, and this is an elegant paper in the NEJM by the Pioneer Heart Failure investigators. Similarly, in the Paradigm Heart Failure, you can see within 10 days of randomization, the curves are separating out, and at the end of 30 days, they're nicely separated out. So a lot of the benefit is early. And the reason for this is you can see that the NT-proBNP and the troponin T values, the difference between the two groups is apparent within 4 weeks and was sustained at 8 months. Another group of investigators showed that with ARNI, plasma aldosterone, plasma endothelin, and NT-proBNP all improved within day 21. So, but it was as early as 1 week. So the key take home is early therapy is beneficial, and there are papers now showing both in vitro and in vivo and mice models that ARNIs are beneficial in chemotherapy-induced cardiomyopathy. And there have been case series where using ARNI in heart failure due to chemotherapy, that they are very favorable. More recently, our neighbors from Indiana had an abstract in the ECC showing the benefits of ARNI both in Adriamycin and trastuzumab-induced cardiomyopathy. Clearly, we need more clinical study or large registry data to validate these important findings. Another key takeaway is based on the Paragon heart failure, the FDA has approved ARNIs for patients with HFpEF. Now, the new kids on the block are SGLT2 inhibitors, and the benefits are substantial. In the DAPA heart failure, there was a 49% reduction in events by day 28. In the soloist acute heart failure, there was a 39% reduction in events by day 28. And in the Emperor reduced, the benefits reached statistical significance as early as 12 days after randomization. I'd like to thank Dr. Greg Fonerow from UCLA for sharing this slide with me. And when you look at the emperor preserved the survival curves separate out as early as 18 days, and so the benefits of MRAs, ARNIs, and SGLT2 inhibitors are right off the bat within the first month. And more recently, there have been papers and abstracts showing the efficacy of SGLT2 inhibitors in chemotherapy-induced cardiomyopathy. In this very elegant paper in JACC heart failure, they found when SGLT2 inhibitors were started when the blood pressure was soft, there was actually a slight increase in systolic blood pressure when the blood pressure was less than 110. There was no change when the systolic blood pressure was between 110 and 130. And there was a slight reduction in blood pressure when the blood pressure was greater than 130. So the effect of SGLT2 inhibitors is bimodal, and so one must not hesitate to start therapy when the blood pressure is soft. This is no different with Carvedilol in the COPERNICUS trial. When patients were treated with Carvedilol when the pretreatment blood pressure was between 85 to 95, there was no decline in blood pressure. In fact, there was a slight increase. In fact, if you look at this upper panel of this graph, there's an increase in blood pressure when the blood pressure is soft. In the lower panel, it shows in all comers the blood pressure is reduced. And again, I think because of its alpha-1 blocking properties, it's got very favorable tubular glomerular effects, which will allow it to have this bimodal effect on blood pressure. Milton Packer and John McMurray have argued that the step one in the management of HFrEF involves starting beta blockers because of its antiarrhythmogenic efficacy and SGLT2 inhibitors. And I would argue that both these classes of drugs also improve soft blood pressure. And if the blood pressure increases, then it's easier to roll out the ARNIs and the mineralocorticoid receptor antagonists. Whereas Greg Fonarow, Javid Butler, and Stephen Green, in a very elegant editorial in our viewpoint in JACC Cardiology earlier this year, have argued that ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors should all be started right off the bat on day one at the lowest dose, and then to titrate over the next few days as tolerated. And as I've discussed, the mortality in the first month is 10% at least with HFrEF. So it is really important to start early and titrate up to max dose GDMT as tolerated, preferably within a month, because it saves lives. In fact, the key takeaway from today's talk is door to GDMT time and door to max dose GDMT time. In fact, I would argue door to early GDMT therapy in LV dysfunction is vital. Being tardy may be deadly and fatal. Early to start and early to max dose GDMT therapy is the key, particularly in those with an elevated BNP. This will save lives much more than many. In fact, I would argue that it is really important to educate our referring docs, cardiologists, hematologists, and oncologists to initiate GDMT right off the bat, because it may take a while to get into your clinic. In fact, I try to see the patients the same week after I get the referral for HFpEF and HFrEF, particularly in our chemotherapy-induced cardiomyopathy patients, because time is the key and we may save lives right off the bat. Often, if the patient can be seen, encourage the oncologist and the hematologist to start at least beta blockers and mineralocorticoid receptor antagonists if there's no kidney dysfunction. And many of the patients are diabetic, so it's easy to get approval for SGLT2 inhibitors. As you all know, the biggest challenge is getting approval for some of these newer medications from the insurance companies. Sooner or later, we will all have to have a pharmacist-driven GDMT clinics, just like we have clinics for anticoagulation. The GDMT clinics will help titrate the dose of these patients to maximum dose, so they're on optimal therapy. And so this is the future. I hope you have found this thought-provoking and has made a difference on how you will manage your heart failure patients in from now onwards. Thank you.